Good afternoon, everyone, and I welcome you all to the 108th session of e-NISCHIT. That's our collaboration of TB and HIV, NACO, with NACO and Share India. So I welcome you all. I welcome all the ART centers who are joining us from Andhra Pradesh, Arunachal Pradesh, Assam, Manipur, Meghalaya, Mizoram, Nagaland, Tripura, Tamil Nadu, and Sikkim. I welcome you all. It's a very hearty welcome. And so we will begin the session. And before that, I'm Dr. I'll introduce my panel. I'm Dr. Ananya Prabhu, chest specialist at NITRD. And with me on the e-NISCHIT team is Dr. Jyoti from Share India. And Shifa is helping us with the logistic part and IT part from Eco India. So I'm today the case will be presented by Dr. Pooja. So I welcome Dr. Pooja. She's from ART Center NITRD. Well, I welcome you, Dr. Pooja, to today's session. And I'm very glad and delighted to introduce our expert for today. So that's Dr. Alok Yadav. He's CMO NFSG and Pediatrician at National Institute of TB and Respiratory Diseases. And welcome you, sir. And he has a vast experience, over 15 years of treating both adult and children HIV. And I'm sure we are going to be totally enlightened today by his didactic and we'll have a lot to learn through. So I welcome you, sir. So as I said, so today's agenda, to go through today's agenda, today we will be talking about CLHIV. So CLHIV is a topic which has not been touched so much in the eco session so far. So I'm glad that we could take up this topic today. And as we all know that this spectrum of CLHIV problems, first it just hovered around just the mortality part, whether the child will be able to survive or not, and whether how just the mortality part, perinatal, infant mortality. But now this, because of the effectiveness of the ART drugs, the children are surviving and they are trying to live a normal life. So the spectrum of problems have changed. Now the problems are not dying with HIV, it's the problem of children living with HIV and the challenges that they have living with HIV. And the challenges start from the first, it starts based from very basic detection also, because a growing child failing to thrive, there can be like multiple issues that come in the mind, and HIV is generally not the first thing that will come to any clinician mind unless until the parents are HIV and they disclose it to you. So that would be, it would be not be an understatement if I say that that would be one of the last thing that you will think if a child is not thriving, because you think of so many growth problems, think of so many physiological and pathological problems before you think of something like HIV, something as serious like HIV in a child. So right from detection to the point that even if you detect it and then you have to coax the child and the parents and counsel them for taking the access to the treatment, going to the ART center, that itself is a big challenge because the huge stigma. We have seen cases in our ART center where the parents are HIV positive, and if the child has remained HIV negative and turned out to be HIV positive after some time, so children, even the parents don't want the child to go take access to go to the be open about his HIV status, because they know that maybe through the child the world will come to know about their HIV problems, and the child how will he deal with his own psychological issue. The psychological issues are huge. Even they start from the age, it's not only the adolescents that are facing the psychological issues with HIV. Even very young children, the psychological issues are huge, and they play havoc on both mental and physical health of the children. So this topic deserves attention, a lot more attention, and a lot more research than what has been currently been doing. And I'm glad that now the tides have started flowing that direction, and there's a lot of research on CLHIV now, and it's just not that replica, and it's just not that whatever adults have been and we just try to follow that in CLHIV. Now people have risen up to the fact that this topic itself needs and warrants much more research and much more thinking, because we are dealing with children who are physiologically very different from adults, who are psychologically very different from adults, and who do not have if adult gets HIV, he had a good immune system, and then he got HIV, which got injured by that, and now it's combating that. But a child, it can be just an underdeveloped immune system which gets hit with HIV. So you can imagine the catastrophe. So having all said that, I think it sets the background that why today's topic is so very important to all of us, and so important for all of you patient listening to it. So I'll invite Dr. Pooja to finally present the case today. Yes.
So the case today is of a 10-year male child who was brought to our emergency department of NITRD on 25th of December 2023 at 10:30 p.m. So the parents of the patient were complaining of fever, which was an on and off mode, and this was not associated with any evening rise and was relieved by taking antipyretics. Then they complained of cough with expectoration, which was not associated with any seasonal or diurnal variation, and it was not associated with hemoptysis. Also, he was complaining of pain abdomen, which was dull aching in nature, and it was not associated with nausea and vomiting. He complained of loss of appetite and loss of weight, and he was saying that he is having trouble breathing. Then we took the history of the child. We asked about the family history, but we couldn't find anything significant at that time. But later, upon working the child, we came to know that he is HIV positive, and we also tested their parents who came out HIV positive after the testing of the child. Also, on prior asking the mother, she didn't reveal her TB status, but later we came to know that the mother also had TB in earlier stages. Then we went for the workup of the child. On general examinations, the vitals were as mentioned, like the pulse rate was 108 and BP was 102 upon 60, and SpO2 was 97% at room air. And the systemic examination revealed that the respiratory system was showing bilateral bronchial sounds. And then we went into the background of the disease. So the patient was apparently well. So, since last 2 months, he's suffering from the same symptoms, had taken treatment in different private hospitals. So, first of all, he was taken to Green Park Hospital in a private setup where he was showing a persistent increase in TLC count from 19th of December 2023 to 23 of December 2023. And then there was a sudden decrease in his hemoglobin level, which was 6 gram per DL on 19th of December 2023. Then it was corrected after treatment. It was corrected by 22nd of December 2024. Also, he was worked up for CECT imaging at that time, which revealed infective bronchiolitis with necrotic mediastinal lymphadenopathy and bilateral pleural effusion, which was more onto the left side compared to the right side, and it was suggestive of a tubercular etiology. Then the patient was dissatisfied by the treatment at the private hospital. The patient was brought to us at the NITRD, where we did all the workup. And the workup on the workup, we have mentioned the CBC on different consequent dates. You can see at the bottom of the page. The X-ray revealed miliary tuberculosis based on. We also checked the serology of the patient, which revealed that the patient was HIV positive. We took the serum through 3 tests and then confirmed the HIV status of the patient. The CD4 count of this patient was 95, and then we started him on ART along with ATT. So the regimen for ART which the patient is receiving currently is AL 600 300 half tablet with AL 6030 1 tab OD, followed by DTG, which is half tablet, meaning 50. We are giving him double dose of DTG, and he is currently on 4C plus 4E regimen of ATT, and we are nebulizing the child on A plus I and supporting him with B complex, iron, and calcium supplement for now.
Your case, for bringing up this case. As I understand that in your experience, like this child came to you, he was 10 years old. It was not that it's 2 years or 3 years old. And when you asked, his parents were not on ART. You have to figure out whether the parents were.
We did the index tracing for this patient.
Okay, so because that's very unlikely that maybe the parents were not disclosing it. So that's another topic and a big discussion there, because 10 years and the parents must be HIV positive for more than 10 years. And maybe they didn't confess. Maybe they didn't.
We tried on the counseling sessions and we tried interrogating them, but none of them disclosed it. But due to our protocols, we checked both of the parents and both of them came out to be HIV positive. Now we are counseling them to take the ART medicines for now. but still they are not ready. We are trying our level best.
Okay, because even ATT she was hesitant in
Yeah,
taking
she's
it, right?
even now she's not ready to take the ART with ATT medicines. According to her, the child is completely fine. Is sitting, is talking, everything is normal for her.
So, yeah, right. So this case really reflects what the real challenge in treating the CLHIV is, that you have to first go through the layers of the psychological issues and stigma issues and people hiding and patient hiding, child hiding. And then if you don't know the real diagnosis, how do you treat it? So it is very difficult. It is very challenging to treat children, and CLHIV is another level. So I understand the challenges that you presented, that in HIV. I will read out to them that you find them difficult to diagnose, you find them difficult to access specimen because they have atypical and variable clinical presentation, and also because the sample or paucity of sample, they are mostly possibly microbiologically, they don't have much of a bacterial load in children. And then there's delayed presentation. And then you also said lack of skilled staff to obtain adequate and specific specimen like gastric aspirate, because they do not produce sputum so easily. Then difficulty in preparing the readiness of the child to accept multiple medicine, yes, definitely. And the establishment of accurate diagnosis and case detection and contact tracing is not routine, which I said, because prima facie you don't really suspect HIV at least. So Lisa TB. So thank you for presenting this case to us.
Thank you, Dr. Pooja, for presenting this case. This is a very interesting case, and the child is right now admitted in our ward. Thank you, Dr. Ananya, for introducing. And right now, this case is presently in the ward. So I just want to introduce regarding the TB HIV situation in the pediatric population. So right now, if you see the global TB report of 2022, near about 10.6 million persons got the TB infection in 2022. Out of them, 1.3 million are death in 2022. In 10.6 million of the cases, adult cases, 1.25 million child got infected for the TB. That is near about 12% of all the TB cases. And 2.14 lakh childs died due to tuberculosis infection. If we further goes into the details, so 1.25 million children, 47% of the children are below 5 years of the age. And in the 2.14 lakh children, near about 16% of the death of total deaths among the TB patients, in which the children who are below 5 years, 76% children died due to TB, and 96% of the death occurred due to non-accessible of the TB treatment. If we come into the HIV part, 31,000, 14% deaths are in the 0 to 14 age group due to HIV. And regarding the TB HIV care cascade, if you see near about 3.5 lakh cases were notified. Out of them, 67% got the TB testing, and 4.4% find HIV positive, and 86% start on the ART therapy. So there is a very big challenges in the children to identify the TB cases under 5 years of the age, especially the death are more under the 5 years of the age. And regarding the HIV, the testing, and regarding the ART therapy is also a very great challenge among the children. So come on this case as presented by Dr. Pooja. This child admitted in our ward, and when we take the history, the chief complaints of this child is fever that is not documented, on and off, and associated with evening rise from last 2 months. Cough with expectoration from last 2 months, pain in abdomen, dull aching pain not associated with nausea and vomiting from last 1 month, loss of appetite from last 2 months, loss of weight from 1 month, and shortness of the breath from last 2 months. So, as you all know that this is the WHO clinical staging in children less than 15 years of age. So, if you see the stage 3, this child has unexplained persistent fever above 37.5 degrees centigrade, intermittent, constant for longer than 1 month, lymph node tuberculosis, also a pulmonary tuberculosis, and unexplained anemia. That is very important in HIV cases, neutropenia and thrombocytopenia. And in the stage 4, this child also have abdominal coughs, as in the reports you say. So this child also have extra pulmonary tuberculosis. So, regarding the TB is the one of the important opportunistic infection in PLHIV patients. If you see the NACO report, near about 56.7% of the TB infection are found in PLHIV group. TB is one of the most opportunistic infections among the PLHIV group. TB, pulmonary and extrapulmonary is the most common opportunistic infection. When the CD4 count decreases, comes into the intermittent level of 200 to 500, the TB infection is most found in these CD4 count group. So why the TB is most common in the PLHIV group? If you see that tuberculosis is the most common opportunistic infection, people living with HIV are 18 times more likely to develop active TB disease than people without HIV. Among TB infected PLHIV, 3 to 10% of the persons develop TB disease per year. 40 to 50% death is due to PTB or EPTB in HIV patient. What is happening generally in the Mycobacterium tuberculosis infection when the Mycobacterium tuberculosis is presented by the antigen presenting cell to the CD4 cells, they release interleukins and interferon gamma and TNF alpha. That also replicate the viral load, causes AIDS and worsening the PLHIV symptoms. And this worsening symptoms decreases the interferon gamma and Th1 lymphocytes counts. So it again causes the Mycobacterium tuberculosis. So in the PLHIV group, the Mycobacterium tuberculosis is the most common, either the reactivation of the TB or got the new TB infection due to decrease of the immunity. So in the early stage, if you see the CD4 count, when the CD4 count decreases in the chronic phases, the chances of the risk of the TB is more in this group. And the viral load is very much and CD4 count it decreases in the chronic phase, then the risk of the TB infection increases. So what are the most clinical presentation of the children's in TB? So clinical feature of the PTB is persistent fever for greater than 2 weeks without a known cause, unlimited cough for 2 weeks, weight loss more than 5%, body weight as compared to the highest weight recorded in last 3 months, or poor weight gain in past 3 months despite adequate nutrition or failure of nutritional rehabilitation in children with SAM. Contact with a patient with any form of the TB in last 2 years. And what are the feature of the extrapulmonary tuberculosis regarding in these children? Lymph node enlargement, chest pain, tightness of chest and respiratory distress. It is due to the pleural and pericardial effusion due to pleural and pericardial tuberculosis. Regarding the abdominal coughs, the symptoms are abdominal pain, distension, chronic diarrhea, vomiting or abdominal mass. If you see the feature in the HIV immunocompromised children's, in the early phase, the sign symptoms is just adult type. You find sputum smear positive and chest X-ray also find cavity. But into the later phase, the symptoms are resembling like primary TB. Sputum was negative, but there is atypical presentation, mid and lower lung infiltration, intrathoracic lymph node are also increases. If you see, most of the children are coming with cough. Basically cough is a very important feature among the children. So cough is of three types, either the acute phase cough, recurrent cough and persistent cough. In the acute cough, the child have cough for 1 to 2 weeks, cough subside, then it recur again. In the persistent cough, it persistent and non-remitting cough, that is not improving by taking the cough syrups. So if the child has persistent non-remitting cough, the sensitivity of these type of children in near about 88% to diagnosis the TB. So what are the method to detect the TB? Sputum. In the sputum, the child is self-expectorant, yeah, induced sputum. Other samples are gastric aspirate, yeah, gastric lavage sample, yeah, nasopharyngeal aspiration. Regarding the specialized investigations are stools, bronchoscopy, EVAS, tissue biopsy. There are some newer investigations are stool, oral swab, and nasopharyngeal aspirations. Bacteriologically test which is recommended by the NTP is genotypic testing, CBNet, as you all know, chip-based net are TrueNet and LPS, and phenotypic testing is BACTEC, MGIT 960. Results are awaited to diagnosis to giving the negative results. We have to wait for 42 days, and the gold standard is still the culture. So this is the algorithm for pediatric intrathoracic TB. The child has fever for more than 2 weeks, unlimited cough for greater than 2 weeks, and weight loss of 5% or no gain in the weight from last 3 months despite adequate nutritional rehabilitation. with or without contact with the patient of pulmonary TB in last 2 years. So first we do the chest X-ray. If chest X-ray is highly suggestive, just like a chest X-ray has miliary shadows, mediastinal lymph nodes are increasing, there is cavities, then this chest X-ray is highly suggestive among the children. So we have to do the sputum, induce sputum, gastric aspirate, gastric lavage, which are NTP approved NET. If in the NET you find the positive report, these are the microbiologically confirmed TB cases. And in this NET report, you find rifampicin resistance detected, then you have to follow up the DITB guideline. And if resistance not detected, treat with first line drugs. In the NET, if you find the negative report and chest X-ray is highly sensitive of TB, look for any other site like a significant enlarged peripheral lymph nodes. Consider repeat NET. Yeah, may seek review from the higher center. If you send the sample from the another peripheral lymph node and from another site, if you find the NET positive, then these patients come into the microbiologically confirmed TB cases. If NET found negative, then if you didn't find any alternative diagnosis, treat as a clinically diagnosis probable TB cases. In chest X-ray is found positive, evaluate for the EPTB. What are the WHO approved respiratory sample for the diagnosis of the TB? These samples which are approved by the WHO is expectorant sputum expectoration, induced sputum gastric aspirate, nasopharyngeal aspiration, and stools. There are some advantage of these tests and some are disadvantage, as sputum expectorant is not feasible for the young children. Induced sputum required equipment, hypertonic saline, and there is chances of aerosol generation, which is also a risk for the healthcare worker. Gastric aspirator, this is the invasive test, which required high level of discomfort to the children, and caregiver acceptance are very low. Regarding the nasopharyngeal aspiration, feasible in the young children, but it is also an invasive procedure, and you required a trained person. Chances of aerosol generation is more in this process. And regarding WHO recently approved stool, this is a non-invasive test and caregiver acceptance is good, but stool it depend on the processing method, which processing you are doing for the examination. So what are the diagnostic accuracy in the expert MTB RIF? Gene expert, the sensitivity of the sputum is near about 65%, and gastric aspirate sensitivity is near about 73%, nasopharyngeal aspiration 46%, stool 61, and stool in HIV positive patient is 70%. Specificity ranges between 98 to 100%. In expert ultra, sensitivity of sputum is 73%, gastric aspirate 64, nasopharyngeal aspiration 46%, stool is 53%, and specificity near about 97 to 98%. This slide I generally prepare for how much limit you have to need to find out this test positive or negative. So in the smear microscopy, the limit of detection is 1000 to 10,000 bacilli, and the sensitivity in children is 15 to 30%. In soil culture, limit of detection is 10 to 100 bacilli, and sensitivity in children 82%. Liquid culture, the limit of detection is less than 10 bacilli, sensitivity is 85%. MTB expert, the limit of detection is 112 to 131 bacilli and sensitivity is 62 to 72%. And expert MTB, if the limit of detection is 15 to 38 bacilli and sensitivity is 64 to 75%. And TrueNet, the limit of detection is 100 bacilli, but there is no pooled data among the children regarding this test. And LAM, which was WHO approved test for generally follow in the adult cases, the limit of detection is 100 and the sensitivity among the children is 84% in one report study. So in these group generally CLHIV, intensified case finding is a very important thing in which you find out these patients by symptomatic screening. Among the adult and adolescent, if they are coming with cough, fever, weight loss, night sweat, and children which are coming with cough of any duration, fever, poor weight gain, and history of contact with TB cases. So you have to identify these symptoms. This is the intensified case findings. So in the intensified case finding, you have to screen the sign and symptom of the TB early, which will help in the early diagnosis and treatment, prevention of the TB infection, and TPT therapy. People living with HIV are approximately 19 times more likely to develop TB disease than those without HIV. PLHIV should be offered TB and HIV diagnostic facility at one-stop services to reduce the diagnosis delay. Sensitivity of the 4S complex is 83%, specificity 38%. And CBNAT is the frontline test to diagnose the TB in PLHIV cases. So algorithm for HIV infected children. If the child is infected with HIV and you are and the child has any symptoms regarding the TB, so the child is TB suspects. So this is pulmonary TB suspect or extra pulmonary TB suspect. In the pulmonary TB suspect, you do one NET and chest X-ray. If NET is found positive, these are diagnosed as microbiologically diagnosis TB. If NAT is negative and chest X-ray is suggestive of TB, then these are the clinically diagnosis cases. If NAT and chest X-ray both is found negative, then there is no TB. In the extrapulmonary TB samples, NAT, you have to find out the culture sample from the extrapulmonary site, and if this found positive, then this comes under extrapulmonary TB cases. Cytologically, histopathologically examination, and any radiologically finding is there, and sign symptoms also suggestive of the TB cases, then this comes under the extrapulmonary TB. So regarding, we have already discussed regarding the intensified case finding. If the symptoms of, you find the symptoms in children's, then investigate for TB and other diseases. If you find TB, then treat for the TB. If you didn't find the TB, then follow up, assist for the TPT therapy. If there is another diagnosis, treat for the that particular diseases and consider for the IPT if it is not contraindicated. And if there is no symptoms, assess for contraindication of IPT. If there is any contraindication of IPT, defer the IPT. And if there is no contraindication of IPT, give IPT. And regular screening is very important by the healthcare worker for the in the each visit. So if there is presumptive TB, if you find in the presumptive TB in the PLHIV group, EPTB smear negative, chest X-ray suggestive of TB, and any vulnerable population contact of DRTB, unnotified TB cases, and non-responser of the TB treatment. First, we do NAT. If NAT you find ref resistance detected and ref resistance not detected. There are two parts. Either you have to find rifampicin resistance detected or not. So if rifampicin resistance was detected, then rifampicin resistance not detected, then send for first line LPA to find out the INH resistance. If INH resistance is detected, then the treatment of drug sensitive TB should be stopped and start for the H mono poly DRTB regimen. And simultaneously, you have to send the reflex testing for second line LPA, liquid culture DST for moxifloxacin, pyrazinamide, linezolid, and clofazimine. If there is any additive resistance is found, intolerance or non-availability of any drug is find out in the reflex testing, then modify the H mono poly DRTB regimen. And if back and if rifampicin resistance is detected, then you have to send the second specimen for culture and DST. You have to send the investigation first line LPA, second line LPA, liquid culture for pyrazinamide, bedaquiline, clofazimine, moxifloxacin, linezolid, and delamanid for these particular drugs. After completion of the pre-test evaluation, start the DRTB regimen. If there is no additional resistance or H resistance detected with CATG or INHA mutation, not both, and FQ resistance not detected, then these type of children are eligible for the shorter regimen. If the H resistance detected with both CATG and INH mutation or FQ resistance detected, then these are eligible for the long oral regimen. And additional resistance or intolerance or non-availability of any drug in use or emergency are exclusive criteria for the shorter regimen. So if you didn't find any sample in the children's, because sample taking is also very difficult. So if the child had TB and if you find this DRT or DST, if you find the drug sensitive, then confirm treat for as a DSTB. If you find drug resistance, then treat for the DRTB. But in case you didn't find any sample from the child, then you have to evaluate the contact. If the contact in infectious TB patient source is DRTB, consult for the pediatrician, reattempt DRTB DST on a appropriate specimen from the child, even if required. Invasive testing for ball. If still you didn't find any resistance pattern, then you have to treat these type of the children for drug resistant TB. If the source of the patient you didn't find, then try to do DST, DRT of child or source specimen. If the source is found drug sensitive or drug resistant, treat this patient according to them. And if the drug sensitive treatment child is not improving by the drug sensitive treatment, then you have to re-evaluate these type of the children for the drug resistant cases. So the drug dose of the children. So basically, in the children's in drug sensitive cases, isoniazid is 10 milligram, vary from 7 to 15 milligram. Maximum dose is 300. Rifampicin is 15 milligram. Maximum dose is 600 milligram. Ethambutol is 20 milligram. Maximum 1500 milligram. Pyrazinamide 35 milligram, and maximum dose is 2 gram. And these are the weight band regarding the dispersible tablet nowadays available: 4 to 7 kg, 8 to 11, 12 to 15, 16 to 24, 25 to 29, and 30 to 39 as per body weight band. But in the intensive phase, the drugs of pediatric age group is HRZ, which contain 50, 75, and 150 milligram. Ethambutol is given as a separate drug. In the CP phase, HR is in the dose of 50 to 75, and ethambutol is given separately. So the pediatric treatment is divided into the two part: drug sensitive and drug resistance. In the drug sensitive cases, if the child is new or previously treated case and HNR sensitive, then the regimen for IP is 2 HRJD, total 56 dose, and dose of CP is 4 HRE, total dose is 112 dose. In case of the drug resistance, if the child is H mono poly DRTV regimen, then the regimen is 6 month of levofloxacin REZ, and if you start the shorter oral bedaquiline regimen, then the regimen is 4 to 6 months of bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose INH, and ethionamide. And in the CP phase, 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. In case of the injectable containing regimen, bedaquiline is replaced by the amikacin, kanamycin, and levofloxacin is replaced by the moxifloxacin. 4 to 6 months of the moxifloxacin, kanamycin, amikacin, ethionamide, clofazimine, pyrazinamide, high-dose INH, and ethambutol. And in the continuation phase, 5 months of moxifloxacin, clofazimine, pyrazinamide, and ethambutol. If the child is eligible for the longer oral regimen, then 18 to 20 months of the levofloxacin, bedaquiline for 6 months, linezolid, clofazimine, and cyclosporine. So right now, the severity of the disease is very important among the children to start the shorter or oral regimen, shorter or all oral longer regimen. So non-severe form of the TB is interthoracic lymph node TB without airway compression, uncomplicated TB pleural effusion, paucivacillary non-cavitary disease confined to one lobe of the lung without miliary pattern. Extensive TB diseases is bilateral cavitary diseases, extensive parenchymal damage on chest radiography in children under 15 years, presence of cavitary or bilateral diseases on chest radiology. Severe EPTB is presence of miliary TB, TB meningitis, CNS TB, spine TB, abdominal TB in children is under 15 years, extrapulmonary form of TB other than lymphadenopathy, that is peripheral lymph node or isolated mediastinal lymph node without compressing. These are excluded in severe EPTB. So before starting the DRTB regimen, we have to do the pre-treatment evaluation in which height, weight, and history and physical examination and psychiatric evaluation is very important among the children. In the laboratory part, we do HIV testing, random blood sugar, complete blood count, liver function, thyroid testing, urinary examination, electrolyte, sodium, potassium, magnesium, calcium, chest X-ray, ECG, and pregnancy testing women. So these are the drug classification you all know in group 1, group B, and group C. In group 1, levofloxacin, moxi, bedaquiline, linezolid, and group B is clofazimine, cyclosporine, and group C we discuss in the next slide. So what are the principles to making a regimen among the DRTB children? Basically, the first preference we have to giving the drug which are not used and DST show sensitivity. Second preference is given to drugs not used and DST results are awaited. Third is drug used DST show sensitivity, and fourth is drug used DST results are not available. And drug not used DST show resistance. Yeah, any resistance pattern find out in the DST. These drugs are not should not be used. So regime prepare as per the sequence of the drug listing in group ABC of DRTB classification. Replacement sequence in the group C drugs are delamanid, amikacin, pyrazinamide, ethionamide, PAS, ethambutol, and penims. These are the replacement sequence if you are adding these drugs. And if you are not using the group A drug or group B drug, then group C, only group C one drug can be added. If two drugs from group A or group B needed replacement, then add two group from group C. If three or more drugs from group A and group B need replacement, then add three group of group C. And these are the replacement sequences. Right now, NTP approved the use of the bedaquiline in greater than 5 years or weight greater than 15 kg. If the child weight is less than 10 kg, then delaminate based oral longer regimen can be started if the age of children is below 5 years of the age. Injectable based shorter regimen is given because BDQ is not approved in this age group. If the age of the child is below 5 years and weight is less than 10 kg, then injectable based regimen is only recommended. So the important for the TB treatment is to correct the categorization. As we discussed regarding the new and previously treated H resistance cases, I am focusing regarding the DRTB treatment regimen. If the treatment is non-severe rifampicin resistance MDR-TB shorter regimen, if the child required, then the regimen is 4 to 6 months of bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose INH, and ethionamide, and 5 months of levofloxacin, clofazimine, JAD and DE. But if the age of the child is below 5 years, bedaquiline need to be replaced by the amikacin in the non-severe cases shorter regimen. In the all oral longer regimen, the bedaquiline, levofloxacin, moxifloxacin, linezolid, clofazimine, and cycloserine. If the age of the child is below 5 years, drug need to be replaced of bedaquiline by the delaminate. If weight is greater than 10 kg and amikacin is weight is less than 10 kg, basically. So what is non-severe TB is intrathoracic TB smear, culture negative TB bacilli with or without NAT positive, lesions only confirmed in one lobe with non-cavitary uncomplicated pleural effusion or isolated mediastinal lymph node without airway compression and no sign of the biliary TB. And EPTB peripheral lymph node TB only included in the non-TB in a non-severe form of the TB. So regarding the ART initiation in PLHIV, so TB HIV TB cases, ART should be started as soon as possible with 2 weeks of initiation of the TB treatment regarding the CD4 cell count among PLHIV. Among PLHIV with TB meningitis, ART should be delayed, defer for 4 weeks and initiate after 8 weeks after treatment of the TB meningitis is initiated. Corticosteroids should be considered as adjuvant treatment for TB meningitis. So TB, if you are using the rifampicin, as you all know that rifampicin is an enzyme inducer, it induces the P450 enzyme cytochrome 450. So in these regimen, the dose of DTG dolutegravir need to be doubled initially, and it should also be continued after stopping the TB treatment regimen for 2 weeks or longer. And lopinavir and ritonavir generally super boosting is needed if you are using the rifampicin based regimen. Generally, lopinavir and ritonavir you are using 1:4 ratio, but if you are using the rifampicin, then these super boosted dose at the rate of 1:1. If average no modification is needed, and in case of the dolutegravir and lopinavir ritonavir regimen, then this dose need to be double of dolutegravir, and lopinavir ritonavir need to be super boosted. Children in the treatment of CLHIV is confirmed HIV cases, stabilize the child, acute opportunistic infection, baseline investigation, CD4 count. If the age of the child is below 6 years and weight is less than 20 kg, then the regimen is avacavir, lamivudine, and dolutegravir. And if the age is 6 to 10 year and body weight is 20 to 30, then the regimen is ALD, basically lamivudine and dolutegravir. And if the age is greater than 10 year and body weight is greater than 30 kg, then the regimen is TLD, tenofovir, lamivudine, and dolutegravir. Recently, under the age of 6 year and body weight 20 kg, dolutegravir is now approved by the government of India. Next. So regarding the BCG vaccination is in neonates, it is very important in the newborn. So BCG vaccination generally is recommended as per the national guideline. BCG vaccine is recommended in all the neonates, that is given intradermal in the left deltoid region. So BCG vaccine reduce the risk of the transmission among the children under 5 years of age regarding the very severe forms of TB, disseminated TB, TB meningitis. So what are the WHO recommendation now? WHO neonate born to the women of unknown HIV status should be vaccinated, as the benefit of BCG vaccination is more than the risk. Neonate of unknown HIV status born to HIV infected mother should be vaccinated if there is no clinical evidence suggestive of the HIV infection regardless of whether the mother is receiving ART. Neonate with confirmed or even virological testing, VCG vaccination should be delayed until ART has to be started and the infant confirmed to be immunologically stable. CD4 count is greater than 25. And NACO recommend that BCG vaccination at birth to all HIV exposed babies. If BCG not given to at birth, it should not be given to symptomatic older infants and the children. So now we come into the TB preventive therapy. That is a very important part in the PLHIV or CLHIV. So TPT decrease the risk of developing the TB disease by approximately 60% and 90% among the people living with HIV. Effective implementation of the TPT has shown to reduce the annual incidence of active TB by 8.3%. A RCD trial in 2009 so that IPT so overall risk of TB by 33% and preventive effectiveness reaches 64% of the people with positive TST. So targeted population for the PLHIV group is people living with HIV on ART, adult or children greater than 12 months of age and infant below 12 months with HIV in contact with active TB diseases. Household contact below 5 year of pulmonary TB cases, household contact of 5 year and above of pulmonary TB cases. And now the TPT is extended to the target population who is individual who is immunocompromised, have silicosis on anti-TNF treatment on dialysis, prepare for organ transplantation. So these are the extended population, target population need to for the TPT therapy. So all TPT therapy, all household contact of pulmonary TB patient, children greater than 1 year age in respect of the TB exposure and children below 1 year of the age with TB exposure. So below 1 year of the age need a TB exposure to start the TPT therapy. Ask for the TB symptoms. If TB symptoms find, investigate for TB. TB found, treat for the TB. If no TB symptoms is found and age is below 5 year, initiate TB preventive therapy. If the age is above 5 to 18 years, the best thing is treat, test and treat. Ideally TPT if LTBI test found positive. But do not withhold TPT if testing is not possible. Then you have also give to TPT therapy to this age group of the children. So TPT therapy recommended for the DSTB. Rifampicin is now widely available, not widely available under the NTP. So current recommendation is continue with 6H regimen and gradually shift to 3HP once rifampicin is incorporated well under the program. Contraindication of TPT is all PI and NNRTI, and you can use in the dolutegravir, raltegravir, efavirenz, and tenofovir age group. The recommendation of the INH is 6 months of INH. If the age of the children is greater than 10 years, then 5 milligram, and age is below 10 years, then the dose is 10 milligram per kg body weight. And regarding the 3SP therapy, only 12 doses needed and it is recommended above the 12 year of the age. And the combination is coming under 150 to 150 milligram of INH and rifampicin. And it is given as per the weight band. TPT for contact of DRTB, risk of TB incidence reduced to 90% of the TBT therapy. Levofloxacin 100 milligram dispersible tablet is available for the children 0 to 14 years. 4 hours should only be used in limited geographical population for evidence generation. So in these cases where the 4 are in H resistance and rifampicin sensitive, in the isoniazid resistance cases 4 is recommended. Dose is below 10 year is 15 milligram per kg per day and above 10 year is 10 milligram per kg per day. And 6 months of levofloxacin in rifampicin resistance cases, if the age is less than 15 year, then dose is 15 to 20 milligram per kg per day, and age is greater than 15 year and weight is less than 45 kg, 750 milligram per kg, and if the weight is greater than 45 kg, then the dose is 1 gram per kg body weight. And in the age group below 15 year, the dose is 50 to 20 milligram as per the body weight band. And contraindication of the TPT is absolute contraindication is active TB diseases, acute or chronic hepatitis, concurrent use of other hepatotoxic drugs, sign and symptoms of the peripheral neuropathy like persistent tingling, numbness, and burning sensation in the limbs, contact with MDR TB cases, PLHIV, and allergy or unknown hypersensitivity to any drug considered for TPT. And adjuvant pyridoxine is also recommended in those cases in which you are giving the isoniazid based regimen and extended to those who have malnourished, HIV infected, renal failure, diabetes, pregnancy and breastfeeding male and chronic alcoholic patient. So the dose of the pyridoxine is because INH interfere the pyridoxine metabolism and inhibit the formation of the active form of the vitamin that may cause peripheral neuropathy. So prophylactic dose among the children is 10 milligram in children, 25 milligram in adult and 50 milligram in adult CLHIV. And therapeutic dose in case of the peripheral neuropathy is 100 to 200 milligram per kg body weight. Thank you very much for listening.
Thank you so much, sir. And it was such an exhaustive guideline, and you have covered it all. So it's very good because it will be staying on our e-NISCHIT website, so e-NISCHIT portal. So whenever it's not easy to imbibe all of it in one go, in one session. So we can always go back to our e-NISCHIT, and because there are such pearls of wisdom along with the way the sir has applied all these guidelines, and revisit this session, so that whenever you have a doubt, you can always relearn and learn whenever you listen to this session. But thank you so much, sir, for making things so crystal clear. And even though it was such an exhaustive topic, but you have just kept everything in the same flow, and thank you so much for that.
So, meanwhile, I just want to highlight what the TPT regimes sir has told us now about the 3 HP, 1 HP, and 4 R. These are available under the NTEP, but the NSEP yet to adopt all these regimes. So, these are in the pipeline, but we have shared, sir has shared all these things for the sake of knowledge. You are treating patients, so you should be aware of what all regimes are available under the NTEP program. So now I will tell you about the post-test answers. So our first question was, which regimen is recommended in CLHIV aged 10, more than 10 years and weight more than 30 kgs as per the NACO guidelines? Option A is abacavir, lamivudine, lopinavir, ritonavir. Option B is abacavir, lamivudine, dolutegravir. Option C is tenofovir, lamivudine, and dolutegravir. So the right answer is option C, tenofovir, lamivudine, and dolutegravir. That is TLD. So the question 2 is, the IPT is recommended in HIV exposed children less than 12 months of age. So the option A is with TB exposure. Option B is irrespective of TB exposure. Option C is contact with drug resistant TB. So our correct answer is option A, with TB exposure.
So that almost brings us to the end of the session, but just a few questions, sir. Like in your clinical practice, sir, like we are sitting in a TB setup, so we know that the child, we have this in our mind that you have a high suspicion of TB. But what advice would you like to give to people who are sitting on ART center and who are not just, or in a general practice? And when we see children are coughing so much in a city like Delhi due to pollution, so there are so many allergic disorders. So cough doesn't really raise the suspicion of TB. Well, what advice would you like to do? Is there any discerning point that you have in your mind that for a general practitioner, for a person who's seeing all kind of cases?
Generally, in Delhi, we are living in Delhi. Generally, each and every child have respiratory, so many respiratory infections and come into the coughing. It's you to identify these childrens which have viral infection, which have tuberculosis infection, which have bacterial infection. As a national institute, we are sitting. So first, we have to rule out the TB infection. So TB infection in the children, it is very important to find out the contact. So contact is a very important thing. First, you have to identify when the child have long cough and that is not improving by any treatment for a such long time, more than 2 weeks, and the parent is giving the cough syrups and taking their own medications. So whenever he is coming into to your chamber, first you have to identify is there any contact history of that particular child with the TB patient. If there is a contact history with the TB patient, so these are the presumptive TB cases. So you have to take these patient considering in the mind, you have to rule out the TB infection. Regarding the below 5 year of the age, it is very important that the TB got very severe form of TB was found under below 5 year of the age. So first line of treatment is first line of investigation is you have to do the CB net if there is contact history. to any of the family within the 2 year, or any death in the family. That is also very important. In the death any family due to the TB disease, and you didn't find out that the patient, that the family member is drug sensitive or drug resistant, so immediately you have to do the testing regarding the CBNet gastric aspirate under the 5 year of the age, and if it is extrapulmonary TB, then you have to find out the sample from that particular site. So contact history is very important. Coughing, unremitted cough for more than 2 weeks, which is not improving by giving the medications, is very important among the children. And regarding the children's weight loss or not gain weight is very important generally. If the TB children's they cannot explain each and everything to you, so you have to take the weight at each and every visit to the children's, and comparing the weight from last previous 3 month weight. If the weight is significant, reducing regarding 5% loss of the weight, that is found significant among the children. So these are important things you have to keep in mind.
Thank you so much, sir. And Dr. Pooja, I would like to ask you, like when you're sitting in ART center, do you see very often children walking in with HIV positive parents, or what do you think needs to be more aware? Matlab, how do you want the HIV adults to be more aware that they should be, looking for saying signs and symptoms in their children?
So actually, I want the parents to realize that the TB infection can be really easily be caught up in the HIV patient. So
Yes.
when we ask the patients about the porous screening and we request them to do the tests like sputum AB and chest X-ray, they're not very much adherent to that.
Even the adults.
Even adults.
Yes.
So we need the parents of those patients, children, to realize ki the importance of TB testing is very much necessary for them. So once we realize that they are the contact sources, because small children, they live most of the time with their parents only.
Yes.
And once we identify these patients that they have TB, so we can prevent we can test the child and we can prevent the patient in an early stage only. But what happens is that these patients don't take the test. So the TB infections it persists in the child also for a long period of time.
Yes.
And when he becomes symptomatic, it's a very long duration of time. Like
already the immunity has taken all the toll
Yeah.
on his body. Yes.
yeah, so that is the biggest issue. Also, we try convincing the parents of those children to get the child being tested early, so that we can realize that he's also an HIV patient and we can start him on ART supplements. Like he can develop the immunity from an early stage, but parents do not cooperate very much. It is very tedious to make them understand that the child can also have the HIV infection and he also needs to be taken care of and being taken care of at an early age.
Yes.
So this is a very big drawback we are trying to cover.
Because even the HIV positive, well, they want to have children and they are having children, they will go ahead with that, but then they have to take this responsibility also of being. So I completely agree, because most of the time when we ask our patient, they say that nahi, bacha hamare saath nahi rehta hai, bacha is staying with the grandparents. They just want to give it some excuse that how the child is protected by them. So we need to be more proactive. Maybe more healthcare workers should be there, so the contact tracing can be done for the child and no child is left ignored, especially HIV positive children, because of all the dual sword that they will be facing. So
I would like to ask you, like in children, we are getting difficulty in collecting the sputum samples. Like it is not very much easy to make them expectorate and get the sputum AB samples. So is there an alternative other than the sputum, like giving him nebulization or something that we can use in the patient or at an early age to collect the samples or something like that?
Basically, regarding the sputum samples, the child is difficult to expect the particular sample. So the yield is also less in the direct sputum sample. So yeah, either you have to induce the sputum by giving some nebulization. So after giving the nebulization, you have to motivate the child to cough, and also giving the percussion on the back of the child, so that he can expectorate the correct sputum sample. And in another sample, the child who is below 6 year of the age, you can do the gastric aspirate sample. But gastric aspirate sample need to specified and need to be taken by the trained persons who is trained to put up the residue at the correct place and take the sample aspirate. Right now, WHO is approved the stool test also for which among the childrens, but right now NTP has not approved the stool testing and need some more data to consider it under the NTP.
Urine testing.
Retesting.
Urine.
Urine testing basically in the children's we are not doing. Urine testing regarding the CBNet is
Like
I
lamp.
think she
lamp,
urine
lamp.
lamp.
Yeah.
Urine lamp is recommended in the HIV patient, and the sensitivity of urine lamp is also very good among the children's and adult patient. WHO is approved this test. Urine lamp is
Yes.
approved by the WHO. When the CD4 count is less, then you can find out more significant result of the urine lamp test. So it is recommended test among
One
the,
thing
but
that
only in the
resistance will be not.
but you cannot find out the resistance among these. So you have to
But-
verify by the net to start the treatment of DS or
But the
DS.
urine lab test is not available in the program right now.
It is also a restrictive test, but there is a criteria of something like the patient
The
for
CD4 should be less.
CD4 should be less than 200 and he should not be on ATT. Then only urine lab can be done for
WHO has
that.
recommended and NACP guidelines has also covered that part in the guideline, but it is not yet available in the program.
Okay. So I think one definite recommendation is that the standalone ART centers will have a lot of problems if they don't have a pediatric department or a hospital attached to them, because all the things that sir is talking about, you need expertise in that. And so you will just have a roadblock and you will not go further in that and you will just ignore the child. So I think one recommendation is definitely that all the ART centers should try to link up with a pediatric, with a hospital which has a pediatric department, so that the case can be worked up properly and we do not miss the diagnosis. So with that, we are coming to the end of the session. I would like to thank my case presenter, Dr. Pooja, and of course our expert for today, Dr. Alok sir. Thank you so much. Thank you for making such an enlightening session, and I'm sure that it's a very, very good resource of source of information that we are going to put on our website now, and for us to benefit anytime and every time we want to go and back and read about CLHIV. Thank you, Dr.
So,
Tulsi.
Yeah. I request all my participants to revisit the YouTube channel as and when required, so that you can brush up your knowledge. And today's session was so very important, and Dr. Alok has touched upon the very crucial things. I know it was a long session, so always it will always be benefited that if you'll see it again and again, like he has touched upon not only for the prevention, not only the TPT, but he has also talked about the vaccination and the double dose of BTG if the patient is on rifampicin based regimen. So the cough duration, CLHIV of any duration, cough of any duration is considered as a presumptive TB case. So there are lot many points which need to be retained in our memory. So I thank Dr. Alok for such a good didactic. I thank Dr. Pooja to bring up such a nice case, and that was high in need. And I thank Dr. Ananya for moderating the session in such a nice way. I thank my team, Ms. Shifa, who is supporting us with the IT thing. And lastly, I thank all our participants who make this session successful with their presence. Thank you all. Thank you very much.
Thank you.
Thank you.
Thank you.